Dr. Bill Adams here, and we have a great special edition of No Spin Live for you today. I've got two excellent experts with us. We've got Dr. Tom Wiener, who many of you know from our previous special editions on COVID, but we have a special guest expert, Dr. Lee Merritt, who's an orthopedic surgeon in the Omaha area. So Lee, thanks so much for coming on.
Thank you. Thanks for having me.
And Tom, Tom, you're just south of me in Houston. Everything okay there in Houston?
Everything's okay. We're not in lockdown yet.
Yeah. All right. Well, hopefully you won't be. But Dr. Merritt has expertise with regard to COVID and many of the things that I think viewers have questions about, whether it be masks or lockdowns or treatments, vaccines, and I think we're going to get her expert opinion on many of those. Lee, I wanted to start because we hear this, Tom and I and some others have had some experience doing some programming around COVID, and what we hear sometimes, hey, you guys are plastic surgeons, you don't have any business commenting on this. So I want you to detail for people, you're an orthopedic surgeon, but you're really beyond that, and tell them a little bit about kind of your history, and especially how you came to being an expert on this topic.
Well, thanks. I have to say, part of the expertise here is you have to have a little common sense, which seems to be in short supply here. But I graduated at the University of Rochester, New York, and then I went off to the Navy, and I was going to be an internist. So I did an internal medicine residency, and my claim to fame is I fell asleep in front of Tony Fauci. I said that at a lecture one time. But after I got out, and I did an orthopedic residency and spine fellowship, and then after I got out of all that, I'd been in the Navy for 10 years. I'd been hanging out with senior level military people. I took a position for several years on the NRAC, which is the Navy Research Advisory Committee. And what that is, we look at technology for the Navy and for other services, but mostly for the Navy. And by law, this is a congressional committee that has to have a doctor on it. And I tried to make myself useful by looking at things, and we researched all sorts of stuff. I looked at the Gulf War syndrome. I looked at, should we keep our hospital ships, that kind of thing. But one of the things I looked at was, I really wanted to understand what the deal was. When they gave everybody anthrax vaccine, which wasn't given when I was in, it's like, what's this all about? Why are we so afraid of anthrax? So I started looking around, and I really started studying smallpox. And one of the reasons that my ears started picking up in this whole COVID thing was, I know that masks have never been shown to work for viruses like smallpox, which is a slightly larger airborne virus than this. And a lot of the things that they were saying about COVID, I just felt were, at first I thought, could I be wrong about this? Like most people, I was confused. I thought, how could these people be saying so many crazy things? And then I realized it wasn't by accident probably, but it was consistently wrong. Everything Dr. Fauci said was consistently wrong. And I said, this cannot be by accident. What is going on here? And that's really what got me interested. And then I just, like many of you probably that are elective surgeons that were somewhat unemployed, I sat hours and hours at my computer researching everything. And I had the advantage too of being connected to organizations that connected me to these doctors all over the world, like Dr. Raoul in France and Dr. Zelenko in New York, through the emails, and I could hear what they were saying and talk and ask questions, and that was really unbelievable. We had an unbelievable back and forth, so people could learn what to do and what was really going on.
Are you still doing any work with the Navy in terms of bioweapon stuff? Is that
no? I'm off the NRAC.
Okay. All right. Well, let's get into some of this. So, Tom mentioned it, but I think a lot of people are hearing around the world about, we're going to lock down again. So that's been a strategy that was employed from the beginning. Maybe had some reason before we knew more about this virus, and maybe wasn't completely unreasonable in March. But what are your thoughts on just lockdowns, and especially at this point, what would you tell people about the whole lockdown strategy?
Well, I'm with you. I thought when this thing first came out, and I have a friend that used to be at USAMRIID, which is our bioweapons defense lab, let's say it nicely. And I would call him when things broke out, and I would say, hey, should I be worried about this? And up until now, he's always said no. But when this was coming across out of China, he said yes. So I sat there glued to the computer, because I know that we are creating bioweapons in the labs, and the worst one I knew about was smallpox. And in contrast to this, let's keep in mind, smallpox was 60% fatal. And you've heard the term dark winter bandied around by the politicians lately. Well, dark winter was a war game that looked at smallpox that predicted we could kill 2/3 of the world's population in a matter of months. We are not vaccinating for that. So there's some real issues out there. But this one didn't bother me at first when it was just in China. But when it started killing people in Italy, I thought just the same way as you, especially when doctors and nurses are dying. I said, okay, if we can't save ourselves, there's something bad going on here. So that's when I said, okay, it makes sense to at least shut our borders. I never thought we should lock down the whole economy, but I did think we should shut public transportation and the borders until we knew what was going on. Well, it didn't take long before we knew what was going on, and we knew that there were ways of mitigating and treating it. And the problem is that now we've never come out of that. I mean, if you look at the problem with lockdowns, the problem with masks, we live with viruses all the time. And one of the great lies that I've discovered in this whole thing is that we have had an understanding that viruses could be treated by antimicrobial agents going back in probably the late 70s, but for sure the early 80s. And I'm an old fart. I've been in medicine over 40 years. I never heard that. I've got colleagues that were saying professors of medicine, never heard that. My son, who just newly minted general surgeon, never heard that. What's going on? So when you hear people talking now about lockdowns and masks, my point is that can't be a strategy to use every year that one of these viruses can come around. We have now a better understanding how to prevent ourselves from getting sick, how to protect the at-risk population, and how to treat people early so that they don't end up taking up a hospital bed or dying. So it's much better as people are saying, this is a war, this is a virus war. Well, okay, then let's treat it like that. Let's not sit in our basement huddling, because we won't get anywhere that way. And so, then the political point I'm going to make is look at what's happening around the world with these lockdowns. Australia, they're tackling people on beaches when they don't have a mask on. This is insane. You can't go out of your house. I don't want an America where I have to have a pass. Your papers, please. I don't want that. And I don't want the Cheka coming to my house, testing me and doing all that when we have treatment and mitigation.
Yeah, so, and since you mentioned you've done a lot of research on masks, let's just kind of lump that together with the lockdowns. But you've presented some really summarize the data. You've done research on masks yourselves, but what do you tell people about masks? Because it's kind of, you're certainly not towing the party line if you say anything bad about masks now.
Right. Well, and it is a party line. It's not based on science. And in medicine, we always talk about now the new buzzword is evidence-based medicine. But when you look at the evidence of this, it's simply not there. There's a really, really good paper by Dennis Rancourt, and again, he's probably right because he's getting a lot of flack, but he's a physicist, and he was a former professor of physics in Toronto, I believe, and he reviews the literature on masks, and he also talks about the physics of how viruses like this are in the air. They're part of air fluidity. So as his point is, even if masks work, the way we wear them cannot possibly work, because the minute you move masks, viruses are all around us like we're in a fishbowl. And the minute you move that mask off your face, it becomes totally irrelevant. So, I mean, I went out when you mentioned the talk I gave out in Nevada. I'm out in the casino, and you cannot believe in masks when you go out and see that in the same airspace. If you're eating in the restaurant, it's okay. But if you walk 2 feet to the left and you're outside the restaurant, you have to have a mask on. Or people are out using the one-armed bandits and they're smoking and they've got the mask down around their chin. That's just insane. That can't possibly work. So, and then the other thing is the Center for, if anybody wants to review this themselves, it's easy. Go to the Center for Evidence-Based Medicine out of Oxford, and they actually, they miss a couple, but they've got about 16 or 18 papers of the controlled studies on masks, and they show that none of them reach statistical significance for people that want this. The final thing is, I'll say there's only been one randomized controlled study that was on cloth masks, and it was done in hospital care workers, and it was published in 2018 in the British Medical Journal, and they actually showed not only did the mask not work, but the mask actually made the problem worse. In people that wore, in the nurses that were wearing the mask all the time, they had 6 times the upper respiratory infections, and including time loss of work and things like that, than people not wearing a mask. That's a pretty conclusive study.
Tom, what comments do you have on that or questions?
I think as far as mask use, I don't disagree with what Lee is saying. I think that I guess you have to balance it with the concept of viral load, and viral load is the real key to any viral infection. If a mask was perfect, like an N95 mask was perfect in the ICU, then it should screen at least some percentage of the virus, but people are still getting sick. I mean, healthcare workers are still getting sick in the ICU, so obviously that means the mask is not working well or it's not fitted well. Now, as far as cloth masks out in public, I think that they're fairly useless, and even the regular ear loop masks. What they're probably doing more than anything else is if someone is coughing up big goobers, yeah, it's catching those, obviously, big droplets. But as far as the microscopic or the actual aerosolized virus, it may be reducing it a little bit, but probably not a whole lot. Although you have to balance that, and this is where I'm not as familiar with some of the studies. You have to balance that with what is the viral load and how much, even though a mask might not be a very efficient mechanism, is it reducing the load enough to drop the load below the point where you would get extremely ill? Because the studies that were done on influenza, a few studies on those, and some of the other viruses that have shown viral load issues, it's almost like if you walk in and someone throws some talcum powder in your face, that's a huge viral load. If you can slow that down a little, some people don't get as sick. So how do you balance that? It's hard to say, but I think the cloth masks are virtually useless.
Well,
yeah, I mean, Lee, what do you think about that? Because you hear that sometimes. Even I've seen politicians say, well, maybe they don't work all the way, but it reduces the amount of exposure to the virus.
Right.
And also, why don't you comment too? Will you also, when you answer that, also comment just in terms of the mode of transmission? You keep hearing it's droplets, aerosol, both. The CDC even one point said it wasn't droplets, it was aerosol, and then they switched their thing. So I mean, what are your thoughts on those two topics?
Well, there's a lot of misterminology being run around. And first of all, let me just say that those arguments sound very reasonable. And that's why I think it sucks a lot of people in, including medical professionals. But the truth of the matter, and this whole thing of viral load used to be a big thing. But I will tell you, when you really look at the infectious disease literature, and before this, and I almost don't read anything that's coming out right now. I go back before this whole politicalization of this started. And when you look at those articles, it turns out where we got this idea of viral load was in these artificially contrived studies in laboratories where they used relatively benign pathogens to see if they could produce disease. But they've come around to a different conclusion. And the conclusion is that one virion can cause problems. And it's not, this whole idea of viral load is not the answer. The other point here is when they actually looked at this whole idea, it does make sense that you're not coughing out things. But you and I, and there's two parts of this myth. The first is we are coughing out things. First, if you have a cloth mask, put your hand in front of it. It doesn't take a lot of study. You'll feel it when you cough or sneeze. You'll feel it come out to even moisture come out to your hands. So it's not, the cloth masks are not doing anything. And those of us, you guys and me, we're in the operating room. Think about what they teach you in medical school, that when you are in an operating field, don't turn yourself to the side to get away. If you're sneezing, sneeze right straight ahead because it blows out the sides. And we know that happens. But here's the kicker. when they've actually tried to culture, there was a very good study at the University of Maryland. These are environmental science people. And it's not like we've never looked at this before. OSHA's looked at masks, environmental sciences all over the place have looked at masks. And what they show is that, first of all, the best mask we have is 0.3 microns. Those are the N95 masks. And they only screen 95% of those particles at velocities less than what a sneeze is. Okay, so when you sneeze or cough, you're exceeding the fluid velocity through that mask is rated for. But the second thing is, it's not the big particles that have live virus. They can't culture. Generally, the viruses, when they culture those big globs that we're so happy about catching in the mask, it doesn't culture out virus. Where the viruses are the ones like I'm speaking now, and they just blow out in the air and become part of air fluidity. So one of the studies showed that it might make things worse, because now you're literally not trapping, you're literally trapping things that can make you bacterially sick, but they're not doing anything for the viruses. So to be honest, I don't think any of those things are going to hold up. And one of the reasons I also don't is based on what you look at in the epidemiologically. When you look at, we were talking about Sweden, every country you look at right now and every year has a flu season death curve. I mean, it's a bell-shaped curve. The magnitude may be different and the area under the curve may be different, but the general shape of the curve is superimposable almost from country to country to state to state. But look at Sweden, which did nothing, and then look at England, which did everything, and the curve is the same. The other thing you can look at is when masks were instituted, they still got the curve. In other words, they have many countries, and it showed the countries that had the time to think about this, showed the mask was instituted and 2 weeks later the curve started, or 3 weeks later, or a month later, when they were all masked down. And the final thing I'll say about this is, you and I, when we were, let's say, because I don't know about you guys, but we every once in a while, I mean, spine surgery, I was on the Mexican border for years, and we worried about multiple drug TB and things. And occasionally we'd have some patient that we had to deal with. And we'd wear these N95 masks, which are hateful, but we were fit with them. They come in sizes. We know how to put them on, and we know how to take them off to not contaminate our hands and the rest of us on anything that has accreted on the outside of that mask. What do you see people doing with these cloth masks? Okay, they go to the restaurant, and by the way, the bartenders know better. One of the bartenders the other night said, "Isn't this stupid?" I was waiting for some food. "Isn't this stupid? The guy has to wear a mask to come in here, but then after he gets in 3 feet, he can go to the bar without a mask and go to the booth without a mask." I mean, it's just nonsense. But you see them. What they do is they take off their mask and they fold it up. They put it on the dining room table or the restaurant table. They put their phone on it. Their hands are all contaminated. You see these masks with all this kind of, looks like they've been worn for 3 days and they're all kind of accreted. I mean, it's just not, it's not the same. So that,
I would basically agree with that. The curves and the data, the mask issues and the mandates really don't seem to have done a whole lot, because if you look at the deaths that have occurred, it's still the elderly. I mean, it is
right.
Still vast majority of the elderly. And of course, what Sweden screwed up with, even though I think that their mechanism would have worked, but they screwed up by not locking down the nursing homes early.
Right.
So that was their mess. And to some degree, and certainly that occurred in New York, with that order. But across the U.S., the deaths are still the elderly and those in nursing homes and the high-risk populations. Those are the ones where obviously we should be wearing masks around, but properly fitted, not cloth masks, et cetera, et cetera. Has it made a difference out in the general public? Probably minimal to no. And I think that I think the order for it is just to give a false sense of security, like the government is doing something. And that's almost it as far as the masks. As long as we protect the at-risk population, it doesn't matter if we wear a mask, as long as we're not getting the virus and bringing it into an elderly situation.
Yeah, I mean, the only thing I would add on to that, Tom, is Sweden, self-admittedly, they've acknowledged that was they said they put two inexperienced healthcare workers in the nursing homes. They have big, almost they're almost like hospices to some degree, much more advanced age people and people with medical problems. But despite that, their death rate per capita is certainly equal to the big countries in Europe and around the world, despite that acknowledgement. But I guarantee you, if you look at the data a year from now, they'll be ahead of the game. You're starting to see that now with their death rates and death rate per capita, that like the past 3 months is, I think, one of the lowest in the world.
Right, and the Swedish they didn't shut their schools down. They had 1.8 million students in school all the time, no masks, no social distancing. They didn't have one death, and their teachers weren't getting sick any more than anyone else. If it were really a big problem in schools, I agree with taking care of our elderly in the nursing homes, but I don't agree with locking them down. And it is it's like we put these people in solitary isolation. I wouldn't want to be in solitary isolation for 6 months away from my family when I'm 85 years old. And we don't need to do that, because in terms of prophylaxis now, there's lots of prophylaxis notions coming out there. First of all, the Indonesians, I kept kicking my computer screen saying, for all the billions of dollars we send the CDC, why do they not look at the difference? This is a bimodal disease. Why are they not looking at these people that are dying versus the people that just kind of walk away with the sniffles? Well, the Indonesians finally did what the CDC should have done. And they looked at it and they showed that 96.2% of people, I think it was over 96%, who were either in the ICU or dying had a vitamin D level below 30 nanograms per milliliter. So that's a very low level. We consider 20 to 80 kind of normal, which is not. It probably should be 60 to 120. But in any case, you can't get it in northern climate. You cannot get it from the sun, just being out in the sun. So you have to take a supplement. But that was the big thing. And then 50% of the people that are dying have zinc levels that are deficient. So there's two simple, cheap things we can do. And in India, they prophylaxed in Mumbai, India, where they had 10,000 police people. They actually, and they were worried about them because they're all over the place. They see lots of people all over the place. So what are they doing? Well, 50% of them, they did a study, 50% they prophylaxed with 2 tablets of hydroxychloroquine a week. Now, in America, that would cost less than $2. So it probably costs really a tenth of that in India. $2 a week we could prophylax our nursing home patients. None of the people in the prophylaxis group got sick or died. And they did have deaths and sickness in the non-prophylaxis group. So there's tons of information out there. It's just not being generated. It's not being allowed into the literature. It's not being promulgated. Doctors aren't hearing it. It's sad, but that's what I think we should do for our elderly, not mask down. And I'll tell you one other thing about masks that I really, really object to more than anything, I think. It's an anti-human psyop. I mean, it is terrible for interpersonal relationships. I don't know about you, but I hate it in my medical clinic that I run in a hospital. It makes me feel separated, isolated. It's not good interpersonal relationships. It is terrible for our children. There was a famous study done a number of years ago called the Still Face study, and they had mothers interacting with 1-year-olds and how they laugh and they giggle and they point and they interact with the mother. And then they had the mother turn away and come back and just be still and just look like you would look if you were in a mask, basically. Yeah, you can do some with your eyes, but you can't really be that expressive. And what's happening is the baby takes that for about a minute and then just starts screaming. So they had to stop. They couldn't let anybody go past 2 minutes. And there's a German group that's fighting it, and it's acu2020.org, and they're very good. And there's a psychologist, a PhD type psychologist in Germany, that has a whole video on this. And I think it's well worth, anybody who wants to do this to their children needs to watch that, because when I was asked to go out to the White Coat Summit in DC and speak about masks, and I had the opportunity of sitting across the dinner table from a pediatric psychiatrist from LA. And I asked him this simple question. I said, if we stopped this mask nonsense tomorrow, would our children be okay? And he said, no. He said, we have damaged a generation of children. They're going to have this inchoate fear of the world around them, which it's natural to have viruses and for people occasionally get sick and for some people to die. But we've given them an idea that that's not acceptable, that we have to protect ourselves from everything. And then for littler children, they don't understand what's going around. They're just afraid. And look at all the 20-year-olds that have almost zero chance of death, no matter what situation they're in, and yet they're wearing a mask in their car alone. It's sad to see. So, and what his point was is the children that are older are going to do better, but these young children, this is a hit that they were going to keep with the rest of their lives. And the sooner we stop this masking, the sooner the better for our society.
Yeah. So I want to segue to some things you've kind of already started talking about, Lee. Both treatments, because there's certainly older treatments. There's still debate about those. I know you have some data, and you've given us some already on certainly hydroxychloroquine, but now there's monoclonal antibodies, things like that are being talked about. And then obviously the vaccines that have made headlines in the past week, too, now coming out saying they have had good results from that. So maybe you can comment some more on the treatments and the vaccines.
Well, I'm pretty impressed with hydroxychloroquine, but it's not the only one out there. And I will just say that it's not just the big guys. Now, Didier Raoult is a big guy. I mean, he's an ICU director. He's in a big hospital. He's dealing with inpatients. And he was one of the first ones to come out with a series of 1,100 patients showing that the mortality was much, much less than what they were getting in New York City. And so, and I think it was less than 10% in his ICU and inpatients. So that's a pretty good number for very sick patients. Anyway, but then came out people, and I have a friend who's down in El Centro, Brian Tyson. He started his own urgent care years ago in the poorest county in America. When this started coming out, he looked at what we should be doing, and like the old time doctors, I mean, he just went back, he read the medical literature, looked in the textbooks, figured out some things, like Dr. Zelenko in New York. They figured it out from scratch, and they came up with this protocol of using zinc and hydroxychloroquine. And there's some other things, but that was the start. He screened, my friend in El Centro screened 20,000 patients. He had over 1,900 he treated, not one death and only one hospitalization, and that was short-term for some hydration problems. So that tells you that this should be looked at seriously by our academics. Peter McCullough has come out with now a revised, upgraded outpatient protocol, and it includes hydroxychloroquine, it includes ivermectin. Ivermectin, there was a study of ivermectin, and I'm forgetting, I believe it was a European hospital, I'm forgetting what hospital it was in. It wasn't an American hospital, I don't think. But they showed that if you gave 24 milligrams of ivermectin at the time of showing up at the hospital, when you show up and they think you have COVID, they give you 24 grams, boom, or 24 milligrams, boom, it's over. I mean, apparently it just knocks this thing out. Now, I don't have experience with ivermectin, but I think it's a good thing to try. I think that makes a lot of sense, and I think we're going to see more about that. So I just think there's too much information now to ignore. There was another study that was done. There was an international COVID, and I want to say it was COVID-19 or something COVID-19. There was I used to know the data, the URL, but it was a group of doctors that were uploading studies that was totally transparent. They looked at studies from all over the world, and what they wanted to do was, let's look at the countries that are used to early using hydroxychloroquine versus the people that are not. And unfortunately, most of the countries are not. But when you compare those two groups, the death rate in those countries that are used to using chloroquine and hydroxychloroquine early, it was 78% less than the countries that were not using it. So I don't know how we can keep ignoring that. And, Henry Ford Hospital showed that it was working. They asked for emergency. Now and by the way, hydroxychloroquine, as you know, is FDA approved. It's been around since the early 50s, and chloroquine early before that. So we have a lot of data about this, but we're getting pushback from all sorts of ways. And one of the things is the FDA approved an emergency use of remdesivir, which has not been shown to decrease mortality, in 30 minutes. The 30 minutes they got approval. I think I may be wrong now, but the last time I looked, Henry Ford at 30 days was still waiting. And they had published stuff, they had data. They were an inpatient, academic facility, so it wasn't just anecdotal.
I think there's actually kind of two problems going on as far as medications like hydroxychloroquine. One of which is the financial / political aspect, but the other is I think a little bit. We tend to forget, both as a general public and even as doctors, that antibiotics work by different mechanisms. So, it's not that, let's say, Keflex is going to work, against staph, but there are mechanisms such as hydroxychloroquine. Before all of this started, I had I couldn't remember from medical school how it worked. And then I looked up how it worked. It is not bacteria specific whatsoever. I mean, not even close. It's a completely different mechanism. So I think a lot of times we're ignoring or forgetting the fact that these drugs and these medications, we need to get it out of the slot of saying this one is for a bacteria, this is to help with a virus, this is for a plasmodium. We need to get out of that habit of thinking that way and see what is the actual mechanism the drug and the body use to fight against whatever we're giving it for. And that's what hydroxychloroquine can potentially do, because the mechanism is absolutely fascinating. And it is not bacteria specific by any means.
Right. Lee, you kind of made this point in quoting those different studies, but it's also given early. So you can't say, hey, well, these guys were like, multi-system organ failure in the ICU and the hydroxychloroquine didn't work. That's not where it's most efficacious. It's early. That's what these studies
right. And these things are actually, they're not even really technically antibiotics, they're lysosomotropic agents. And that's where, I think your point is exactly right, though, about the motives, because when I went back into the literature, and I just went from, paper to reference to paper to reference, and I traced it way back, and I went back to 1974, I could find where they were looking at lysosomotropic agents for these novel uses. But by the thing that really got my brain to explode was about 2000, I think it was 2006. I found a paper that showed chloroquine inhibits influenza in vitro. Okay, because and you probably know this now, and like me, I didn't know how it worked either. I'd forgotten, and maybe I never knew how it worked, but I don't now. That it works by acidifying the lysosome, and that's how these viruses get into the cell. That's their birthing center. That's how they reproduce. And so what this does is inhibit the reproduction of the virus, which is why it has to be given early. But it acidifies the lysosome, and zinc potentiates that. But these guys, when I saw that paper, I said, oh, I know why we're not using it, because the $69 billion vaccine industry would go to zero, because there is no reason to have vaccines when you have a treatment in your back pocket. And oh, by the way, another point, and I wrote a paper called The Treatment of Viral Diseases Has the Truth Been Suppressed for Decades, that you can find on the internet. But that I wrote that, and the other point is, if you have a treatment in your back pocket, they can't threaten you with designer viruses. I think this is the nice thing about this is I don't think you're going to get resistance. It's not like you say, it's not like bacterial infections.
Yeah.
I think one of the keys there also, if you compare it to a drug like Tamiflu is widely accepted. In reality, what does it actually do? It reduces the flu duration by 1 day.
Yeah.
And also in certain populations, yes, it can help to tip the balance so someone doesn't get critically ill. But once again, it has to be started early. So what does the instruction say to prescribe Tamiflu? It has to be started within 72 hours. So what these studies for hydroxychloroquine and other drugs like it are doing is they're studying it in critically ill patients that are already in the hospital, already gravely ill, instead of studying it right off the bat when symptoms begin. That's what Tamiflu is prescribed. That's how you're supposed to prescribe it. As soon as symptoms begin, you better start with Tamiflu. If Tamiflu were run through the same gamut that hydroxychloroquine is being run through right now, we'd never use Tamiflu.
Yeah. Well, Lee, touch on, let's go to vaccines, because obviously that's been the big talk in the past week, especially. But what are your thoughts, and what would you tell us about that?
Well, that's an interesting point, and it's not easy to get now there's some papers coming out that are written to the lay public that are reasonably good, but there's a lot of, it was very hard for me initially, not being a geneticist or virologist really, to sort out how this really worked. But I went back to the time of SARS, which SARS and MERS, as you know, are coronavirus, and cats get coronavirus. Anyway, there was after SARS hit, there was a lot of fear about these viruses. So there was a lot of activity about making a vaccine. And I read some of what the researchers were saying. And basically, between SARS and MERS, there were 4 different vaccines that were trialed on animals, on cats and on ferrets. And the side effect was all the animals died. Let me just point that out. They all died. And it was not when they were given the vaccine. And this is a very important thing to keep in mind. When the animals got the vaccine, they were happy, no problem. But as soon as they were exposed to the actual wild virus, they died of immune enhancement. And what that is, you're getting a little snippet of RNA that's like programmed. And the way these things work is they didn't make the antibodies that killed the virus. What they did was they coded the virus. So now the cat or the ferret, they brought this virus in like a Trojan horse, and it overwhelmed their macrophage system and killed them dramatically with cardiac death. Now, the problem is all the vaccine researchers at the time said never, ever, ever bypass long-term animal testing. One of the things that happened is, and I'm going to say this in the order it happened, you can make your own conclusions, that last summer, Anthony Fauci was given $100 million by Bill Gates, who has the controlling share, I think, in Moderna, the vaccine company that's doing this. And he has now given them this year a bypass on animal testing. And in fact, when they say they're doing animal testing anywhere, they're doing it concurrently with human testing. That's not the way this was ever set up regulatory-wise before. They've changed the regulation. They've given him a pass on animal testing. I personally am not comforted by that. So I think this is, and there's just some of the stuff that's so creepy you can't make it up. Like, about adjuvants. Well, the adjuvant in this vaccine is called the matrix. And it also has I think they realized that doctors with some kind of moral background might object to being forced to give this to anybody, and might actually sign off on the paper with the vaccine number without giving it to the patient. We're not going to let that happen. So we put in a chemical in this vaccine called luciferase. Luciferase is the chemical that lights up fireflies. And after you get this vaccine, presumably for up to 5 years and maybe long, but they say for 5 years, I can put a luminometer over you. I can wand you with a luminometer and know that you had the vaccine. Again, I'm not happy about any of this. Now, if anybody wants to take a voluntary vaccine, that's their business. But, to back up just a little bit, the DOD, the Department of Defense, published an article in January of this year, just before this all came out, this whole virus kind of things hit us. And it was they looked at 6,000 active duty, roughly 6,000. They were active duty independents. And they were trying to answer a question about viral interference. It means if I give you a vaccine against one virus, does it make you more susceptible to another virus? Well, they did this on healthy young people. They gave they gave flu vaccine, and they discovered that it increased your risk of coronavirus acquisition by 36%. Now, okay, so that was in the infectious disease literature. If Anthony Fauci didn't know that, if the CDC didn't know that, I was appalled by the fact, I'm an orthopedic surgeon. If I know it, we're in real trouble if they don't know it. And they were pushing flu vaccine in through May. Give me a break. So, it's a matter of trust. I'm not trusting these guys to do the things in my best interest. I've seen too many problems. And if you remember the H1N1, remember the big swine flu debacle, and you guys might be younger than I am, but I remember I was in practice when that happened. And anyway, first of all, they changed the definition of a pandemic. So when this thing came out, yes, it was worldwide, but it wasn't killing a lot of people. They just thought it might. So the ESWI, which is like European CDC, but I always forget what the initials stand for, they declared it a pandemic using this new definition. The upshot was that caused governments to buy all these vaccines and all these antivirals, including Tamiflu, from the big pharmaceutical companies. At the taxpayer dollar, the pharmaceutical companies walked away with $9 billion in immediate benefit. And it turned out that the pandemic was nothing. It fizzled out. But 700 children in Europe that were given this vaccine that was rushed through developed narcolepsy. And they're still damaged. It's a permanent, serious narcolepsy, a big problem. So then they had to, at taxpayer dollars, go and get rid of all this vaccine. And so, the vaccination is not the answer when you have a treatment. I don't think that's the answer. And I think we have not for a long time been told the story of the real damage of vaccines. And I can tell you, one of the things I did do, and then I'll shut up, but one of the things I did on the NRAC was my former internal medicine resident, senior resident, he was now the head of immunology in the Navy and was looking at the Gulf War syndrome. And at first they thought these guys were just kind of crazy, that, it was the stress of war. But they finally realized that all of them with Gulf War syndrome, and it was a lot of different things, but one thing that cropped up, they got ALS at 4 times the background rate. And what they discovered was that they all had their anthrax vaccine out of one batch of the anthrax vaccine, and it had squalene as an adjuvant. Subsequently, LSU or Tulane, I forget, found that all the people with the Gulf War syndrome had anti-squalene antibodies, and none of the people without it. It was not mishy-mashy numbers. So we're pretty convinced squalene caused it. Hue and cry, nobody wanted squalene in their vaccine. CDC said, "You stupid Americans, there's no squalene in American vaccines ever." Until a few years ago, guess what? They put it back in the Fluad. They put squalene as an adjuvant in Fluad. And they labeled it MF59, so even your doctor doesn't know that's squalene and can't put the literature together. Now, I find that just corrupt. I mean, corrupt, dangerous, don't care about human beings. We care about profit. And I'm sorry, I can't come up with another motive there. So I'm very dubious about that. And that doesn't mean I'm against all vaccines. I mean, I would have taken, before all this happened, I always used to say, I would have vaccinated my whole family for smallpox. And that's the one vaccine we can't get. The government owns it all. So I'm not anti-vaccine per se, but we ought to be anti-unsafe vaccine. And I think that the truth and reckoning is going to come out that they have not been truthful about these things.
And how about, there's a couple of these newer monoclonal antibodies that have been talked about. I think Regeneron has one that I think President Trump got, and then there's an Eli Lilly monoclonal antibody. What's your opinion about those type of treatments?
I'll be honest, I don't know that much about them. I think that's an attempt to find something that's when you're actually sick and in the hospital. Of course, We're talking about prevention. I know more about that. So I don't really know. I'm sure they're much more expensive than taking care of people early.
Yeah. So just a little break. I think actually this has been fantastic, but Lee, is there anything that we haven't touched on that you would really like to touch on, or is there any points you'd like to make that we haven't pitch to you?
Well, I guess, like I say, I'm maybe going down the rabbit hole a little bit, but when I sit back and I think, what is this all about? And my, Navy commander hat and my time in the military kind of takes over, and I say, well, this isn't what it appears. This can't be what it appears, because in reality, we've lost 1 million people this year. We lost 50 million in the pandemic of 1918. A couple million in America. And when we had much less of a population. So what is the hue and cry here? What's this really all about? And I got to say, I found it was somebody else online that got me, but I read the book. There was a guy named Biederman, and he looked at the Korean War victims coming back from the Korean War. And at the time, there was a question as, do the Chinese have some voodoo? Why are these people all brainwashed? What's this all about? And he said, no, it's just standard psychologic, procedure. We know how to do this. And the truth is that for 70 years, we have been studying ways of creating fear in a population as a way of control, not just in prisoners of war and not just for interrogation, but to control populations. And if you look at Biederman's, and anybody can do this, you don't have to believe me, just look at Biederman's chart of coercion. It's BIDERMANS, and look at what he says. And it reads like a playbook of what's happening to us. You isolate people. You give them a uniform propaganda. People go into isolation and they sit and they listen to the mainstream media all night long, and they become afraid. So it creates fear. Then you give them crazy unexplainable directives. You wear a mask, you don't wear a mask. Oh, a mask is just so we don't touch your face. That's what Tony Fauci at one time said. Oh, no, it's a mask is to show compliance. Well, mask works in some solutions, but you can take them off here. You know, it makes people crazy, and that moves them from fear to anxiety. And once you get people into an anxiety mode, they will do anything to get out of that mode. It's cognitive dissonance, and people really don't like to be in that situation. So then you have two populations that drop out of that. The resistors, the people that say, this is crazy, I'm not going to do this, this is just crazy, and they stand up and they walk out. And then the other group becomes almost religious in their observance. It's like the Stockholm syndrome, and they obsessively wash their hands, and they do all the things. They wear their mask in the car when they're all by themselves, and they do these things because they're really convinced that's the way to be safe, and they're going to hate anybody that doesn't do them because that's not making them safe. It's fear. And they've done a beautiful job of making us all afraid, dividing us as a nation. It's not right. And it just seems to me that that's not by accident. So
I think if anyone has a question about that, you just look at populations of North Korea and China. I mean, that's population control by fear. I mean, it's fear of death. I mean, you're executed if you do something and move beyond, what the premier says to do. But that's exactly what it is. There is population control. There are so many factors going on with COVID around the world. One of the fascinating things that I just read a few minutes before coming on was that there was a study announced today. I didn't catch when it was published, but a study announced today that it turns out that they now, through aggressive antibody studies, have shown that in Italy, COVID was present in September of 2019. Now, Lee, you're probably not familiar with some of the early No Spin Live episodes, but the very first episode, we predicted that the virus had been present outside of China. I think most of them said October. I think I edged towards September. Cuomo early on or actually late 2019 declared the flu season, the 2019-2020 flu season, as the worst flu season on record, the worst or the second worst. So now we know what's actually going on. If the virus, to get into Italy in September, it moved out of China in September or possibly even earlier.
Yeah.
That means it went to New York far earlier than anyone thought. So this supposed huge flu season, I think if we actually studied what had happened, I think there was a bad flu season, but I think there was a hell of a lot of COVID mixed in there.
Yeah, that's interesting.
Yeah. Well, I tell you what, it's been really incredible discussion. And Tom, thanks so much, but particularly Lee, just incredible insights. And we've learned a lot. I'm sure everybody else is going to learn a lot hearing you talk about this. Thanks so much for coming on.
Well, thank you. Thanks.
Thanks, Bill. Thanks, Lee.
Thanks,
if you want to see more of this, you can see it on theplasticsurgerychannel.com.